So this little blocking screw I put on there actually just prevents those other screws from coming up and becoming dislodged. And then what I'll do is once I have the patient here, I'll actually have the anesthesiologist lift the head up and down, and we'll actually take a movie of the patient to make sure that the total disc replacement is working correctly and that they've got a nice normal range of motion. The other thing we're very careful of, although there is some room for play, we really try to center that total disc replacement right down the middle. And we also make sure that the depth of the total disc replacement allows us to kind of replicate the normal place where the rotation takes place in the average cervical spine.
I think that you brought something to show us on the screen here too, as well as showing the actual, some video of a...
So here we have this is a video of a patient that has a cervical fusion in place. And so you can see here a plate and screws holding a nicely done fusion here, but what's important here is that the disc above, as the patient flexes, is shearing forward. So again, this disc above is actually taking a lot of the brunt that was once shared by this disc, which is now fused. If we now move along to a patient who has a cervical disc replacement, it's a very nice image that is going to show how the motion of the cervical spine remains the same. Now if we look at the disc above the cervical disc replacement level, which it's allowing that disc above to basically function normally.
So more like a normal...
So you can imagine over the typical course of the day or whatever people do in their occupation, the more cycles you have, if it's moving normally, you're going to just degenerate at a normal pace. Whereas if you're having a fusion there and it's shearing back and forth over time, that's going to put that much load on the patient's neck.
So once you've done all this, then you just close up the patient and they're all done?
Yep, so basically once we're done with this, we close the patient. We'll put a small drain in. We'll put a small drain in coming out of the neck. The importance of the drain is that so that the patient does not collect any blood in the area of the neck, because that could make it difficult for them to breathe. So I do put a drain in every single patient, and that usually typically will come out later in the afternoon or the next morning, depending on what the discharge plans are. And then again, it can't be overstated. We really try to make it cosmetically a pleasing wound.
And how long are they in the hospital then usually for?
Typically, my patients, I'll keep them in the hospital for one overnight stay and have them be discharged home the next morning.
Just for observation?
Exactly, and make sure that the drain is not putting out any extra blood or something like that, and then they can go home. Again, their motion can be whatever they feel like they can tolerate. They're not going to injure anything. Sometimes we have to do some coaching on that. And then subsequently, I'll see them back in the office about 2 weeks after surgery. And the important thing we're looking for there is that the incision is healing nicely. At that point, if they're doing well, then we basically let them go out without any restrictions whatsoever in 2 weeks.
Does insurance cover this?
I think that's a great question. Insurance has been somewhat slow to cover this, but I think over the course of the last year and now going into 2010, insurance companies have come to understand this procedure and why it's maybe more effective in some patients than a fusion, but certainly workers' compensation will cover it, auto insurance covers it, and for the patients that we've made appeals to their insurance companies to have coverage on this that don't, we certainly can do things for them so that they can financially afford it. I mean, we can tailor things because the advantage of this may be so great that it's worth it for them to kind of explore those options because, as you know, patients are flying to Europe on a daily basis and paying to have these procedures done, and they can certainly have it done here.
Okay, you're going to be giving a seminar here pretty soon, later this month, and if I can tell the folks about it, it's going to be held on Tuesday, February 23rd from 7 to 9 at the Watson Education Center at St. John's Hospital, Maplewood. It is free, but registration is required. That number to call for registration, 651-326-2273. It's called Back on Your Feet. It is free, but you must register. What will you be talking about at that seminar?
What we're going to be talking about is just your typical bread and butter conditions of the cervical spine and the lumbar spine that can be treated either with injection treatments or with surgery specifically. And actually we're going to have a patient there who's had a total disc replacement done at St. John's Hospital who's doing very well, and she's going to talk about her experiences and how she was able to get back to a normal life